Just for everybody, I'm Chet Morrison. Currently, I'm an associate professor of trauma critical care at Central Michigan University, but for a long time, I was an Army surgeon. I kind of missed my military days, as a matter of fact. And so perhaps because of this, some of this talk is going to have a bit of a military bias, but I'm sure you'll mind that. And as Marilyn pointed out, it is a small world, and there is no way out. And sometimes the water is rising, and those blizzard conditions are out there. And so what I hope you all will get from this talk is that there are things you can do, and that we don't panic, and that these situations happen. But again, there are things that can be done to handle it. Here's where the world gets small. Again, with my title, Military Deployments. Military is very often fighting in hostile terrain in battlefields that now are not static. They stretch across hundreds of miles. And so it brings up the problem of not just evacuating casualties, but you also have the problem of providing care to them as far forward as possible, which is something that we've been refining for, gosh, at least the past 20 years. And we continue to get better at it. Natural disasters have been mentioned. Those are all obviously prominent in our minds. And also, you know, as an Army guy, I will do a hat tip to the Air Force. We do have aircraft, which is great, but the patients need to be taking care of them, as we'll see. When you are taking care of patients and providing critical care in a austere environment, there's really three things to think about conceptually, what you have to do. Incoming, which sometimes you have to actually actively triage, and I'll say a few words about that at the end. The care principles of what you actually do when your patients are there, and also, of course, foremost in everybody's minds when they're in a small unit and they have a lot of patients is getting them out and getting them to upper echelons of care. And this is where you have to leverage your evacuation capabilities. The framework can be thought of in this way. Here's a conventional, you can see this, here's a conventional way we think of intensive care units. I don't think I need to summarize the slide, but this is normal business. We have enough supplies, we have enough staffing. We can actually expand 20%. So if there's a run of patients, or we have like a modern motor vehicle accident, generally there's a 20% capacity. Units usually have, and hospitals by now have contingency plans that, here's the point I want to focus, can expand in a goal of about 100%. Okay? And that's when you have some things like train wrecks, minor disasters, things of that nature. And there's also, they tap on regional and state resources. What sometimes happens, however, and these are fortunately rare, we have crisis situations where you have non-traditional areas, you have the lacking of supplies. This is where you need to do your triage, and in which you are going to be drawing on natural resources, but they may take a long time to get there. And the units are encouraged to have a goal of capacity of 200%, and that's what's going to be needed. That's our framework. Remember this picture? Remember what that is? Let that sink in a minute. That's Hurricane Katrina, of course. These were the staff at the roof of the charity hospital where they were actually reduced to saying this. And what was notable in here is this was in a sense, not just unplanned for situation of austere critical care. But this actually took some time to develop because the hurricane that hit was a Category 3. It blew over. Things worked. The cell phone batteries were charged. And think, well, yeah, we'll just recover from this. Except the water kept on rising and the generator started going out and the communication started going down. And so what was described here was actually a 4 to 5 day period where you had steadily diminishing supplies in which you had to contend with doing procedures sometimes in the dark. Some of our medical brethren there had to handbag patients, but they did, and their survival rate was actually quite impressive. And the other thing was there was a lack of communication, which it wasn't very clear for the people working in the hospital that decisions were eventually being done and help was eventually on its way. Plus the fact that there was civil unrest and breakdown of order. People had come to the hospital just to shelter from the storm and so forth. And so this actually led to the guidelines being developed of not only what you do for patients, but also how you evacuate intensive care units. Fortunately, the triage that had to be done on there was relatively rare. This, of course, is the interior of a C-17 plane. This has its own unique critical care challenges because although the planes work very well, they fly fast, in this particular aircraft can actually land on undeveloped airfields. But still, it's noisy like any other plane. There's cabin depressurization. If you just think about it, you know, how much fun is it to fly in economy class when you're not hurt for 8 hours, right? So think about the pain control that you would have to do. And we encourage pain control pleural catheters and frequent use of pain control measures in this. One of the things that is notable is this one developed from experience. Conceptually put it this way, you're flying a patient. This actually happened in Bosnia. Someone who has a severe electrical injury and polytrauma, and you're on the plane, you're flying him to regional Landstuhl, I think it was. You're in the air, you're several hours out, and he goes into septic shock. Problem. However, you apply the principles of sepsis resuscitation to him. He gets fluid, he gets antibiotics, his airway is secured, and he gets mechanical ventilation. And they actually said he got landed in better shape than when he took off. So with these principles, you can actually make an improvement. And obviously the patient survived. And this got the Air Force to thinking about, well, if it works for one isolated incident, and there had been others, then we can make it work for the large number of patients that this is going to entail. Couple last anecdotes. This is ancient Babylon. This was my stomping grounds back in 2004 when I was in the Iraq conflict. We had a tent, and we would get casualties such as this. Now, the thing with here is, besides the care that we have to do, the surgery, the debridement, and all this, how do we monitor a patient like this? Well, I submit that in these austere surroundings, you not only have your stethoscope, you have your wits about you, but remember, you have things like just perfusion. You can monitor their extremity perfusion, you monitor their blood pressure, you monitor their color. And in this context, though I don't reference it on the slide, we all remember the Andromeda shock trial that came out last year, in which basically they got equivalent results by the expedient of pressing a glass slide on someone's index finger and seeing how long capillary refill took. Okay? Whoa, it wasn't any better than lactate. Great. This is something that's very useful in austere settings. And this, of course, is a picture of something that happened to my Army buddy Joseph Dubose when he was stationed out in the Middle East. Basically, a helicopter crash happened. There were survivors. There were 7 of them, and they were promptly airlifted to his joint surgical team. One, unfortunately, was declared dead on the staging area. 6 were airlifted, and here's the impressive part about this. Actually, there was a lot impressive, but in the interest of time, I'll say a couple of things. One is, one patient actually had a thoracotomy along flight in which he got open cardiac massage, vessel clamping, and he lived. And the second thing that was notable about it is that if you look at the patients who are there, they're getting WFWB. That's walking fresh whole blood. They took 55 units off of the crew members of that ship. And it was actually the whole blood that saved their lives. In fact, it was actually used to treat acidosis. One patient, the one who'd had the thoracotomy, naturally was profoundly acidotic. He improved with whole blood. This is obviously a pitch for whole blood, but it also tells you that with some planning, again, they survived. And it tells you with some planning, with whole blood, and with basically keeping your wits about you, there are things you can do. Similarly, when you're in a rather cold spot of the world, this is Antarctica, in which evacuation is going to travel thousands of miles. And you think, well, who on earth would come to Antarctica? Well, actually, cruise ships come to Antarctica, and they come more. And in fact, while researching this talk, I sort of looked up the trivia point of what's the southernmost city in the world. It's actually in Tierra del Fuego, Argentina, and it's where the cruise ships sail out of. There's not much there, but it is where the cruise ships sail out of. And once again, you think about the evacuation that has to happen and the coordination. But again, it's basic principles. And one of the other things is of course, don't expose your fellow team members to austere environmental conditions. And you also have to think of the dangers. Because one of the other things that happened here is a head injury that was minor but could have been major, which faced the medic, again, one of my former military friends, with the decision of do you evacuate him here or do you evacuate him, over a long period of time because of something that might happen, but if you guess wrong, it's going to be very long. Personally, my recommendation is you play the odds. If you think the odds are that this is not going to require intervention, I think you're very justified in playing it, particularly because you don't want to expose other people to the hazards of evacuation. One last little anecdote. This is Midway Atoll, and it brings up a point I really wanted to mention, which is that when you are doing critical care in austere situations, it may not just be battle casualties or hurricane casualties or pandemics. You also get people with underlying medical diseases that come here. And this happened with one of my colleagues who was treating someone with cirrhosis and a lot of ascites who normally took diuretics, but they didn't have spironolactone. They had Lasix. So what they did is they gave him Lasix, and he had to climb up the coconut trees because coconut water, it turns out, is a source of potassium. And I'll spare you the video, but he sent me one of him fashioning a rope harness and shimmying up the coconut tree and getting the water and coming back down. It worked. The patient had a significant improvement in his ascites and was treated that way. And again, it kind of brings up the principle that you use your resources that you have. Other examples have happened in Turkey, Armenia. You get the point. These things happen periodically. And that's where basically intelligent planning, since we know they're going to happen, as well as personnel resources and training are very helpful. And again, a way of thinking about this, notice that when you get your crisis, again, that 200% figure, that's when your standard of care starts to drop. But in between that, there's a lot you can do. There's a lot of standard of care things. One thing I will leave you with, I really want you to get out of this talk, is that a lot of this information is not only online, it's free. These are the Joint Trauma Service guidelines that were created in these situations. Again, it's on the internet, it's available, jts.amid.army.mil, austere, and it's right there. In fact, in a way, anyone can give this talk. Just go online and read the guidelines, you know? And basically, with limited resources and staffing, you have to kind of plan ahead what you're going to do. And one of the things is rapid triage, initial resuscitation with blood products, control of hemorrhage. This is nothing fancy. You're getting them bleeding stopped. And this brings up the other point that's very, very helpful in any austere situation is ultrasound. I personally, every time I go there, I get some manufacturer who's shrinking ultrasound probes and it attaches to an iPhone or an iPad or anything like that, and the quality of images gets better. So ultrasound is very much something that can help you in this situation. And in fact, it's actually in the guidelines. You don't need to put in central lines, okay? But everyone should know how to put in peripheral lines, IOs, and then rapid infusion catheters are very helpful. They can be put in peripherally, and because they're wide, you can get an awful lot of volume in. You don't have to put in central lines. And in fact, in these situations, it's probably better not to. Your walking blood bank I've mentioned. Again, there's guidelines for this, and that's something that should be thought about. Whole blood works very well in these situations. And you have to give them a reliable system because obviously you want to transfer type-specific blood. You're not going to want transfusion reactions here. Damage control surgery is a part of it. It's all damage control. You're not doing anything fancy. And notice the documentation here, which is not fancy, but understandable and requires no EMR. And in fact, this is a picture from Hurricane Katrina, where the documentation was just paper written around everybody, putting in envelopes and just strung around the patients. No EMR. Oh, well, we have pens and paper available to us. Anesthetic ones, intravenous or intraosseous medication is preferred. Don't get tempted to give people intramuscular. The absorption is unreliable and it won't work. You're better off just giving them small doses of intravenous medication. Your goal is obviously to keep the casualty alive and get adequate perfusion. And we mentioned it doesn't take sophisticated monitors in this setting to monitor perfusion, okay? It does take a clinician who's saying, I think I want to make sure that my patient is adequately perfused. Maintain safety. You don't want your patients agitated and also stopping awareness. Again, it's right on the guidelines. Equipment, you have your universal machines, and most units are deploying within, which can double as anesthesia machines and ventilators. The ventilators usually are your rate-limiting step because there's usually not a lot of them. And in fact, in disaster planning, that's often what disaster planners come down, how many ventilators do we have? They there are adjuncts, as I mentioned, and that can be very useful, and they've done elective surgeries on them. Notice that in this case, and this was written up about the earthquake in Haiti, they used an austere cocktail of anesthesia, just acetaminophen, dexmedetomidine, and succinylcholine. Worked. Because of this, you have to be very careful in the ventilators. This is basically right out of the guidelines for disaster management. And the message I want to get out of this slide is you have to conserve, reuse when you absolutely have to, and when you get overwhelming patient needs resources, or overwhelming patients, your last step is reallocation. Oxygen you have to also be careful about. This is a good slide to point out that my Army buddies Steve Ventisink and Kurt Grathwall wrote this all down in the Critical Care Medicine Supplement, and it's 12 years old, and you know what? That article does not date. Still very, very relevant here because oxygen is always going to be a consideration. Ketamine has been very useful for pain control. And in fact, just hot off the press, there's a meta-analysis that was done recently about just giving people ketamine, and they found that it worked very well. Notice that these are in a lot of military conflicts, but there's no reason that they can't be applied to civilian areas as well, particularly since this is a medication that has a very favorable hemodynamic profile, and of course, like medications, it's relatively portable. You may not have x-rays, but as I said, you do have your ultrasound. And that's very important, and that also should be used liberally. And one of the things that I think people should learn is using it for the abdomen and the chest. It's useful to use in the chest, and it's not always intuitive of what a pneumothorax looks like in ultrasound, but it's a good point to have in your brain. And in fact, this has been written about in the aforementioned Haitian earthquake. When using ultrasound in a field hospital, they felt it influenced care in 70%. 70% of people, which I must say, looking at the data on FAST, was a very refreshing change of pace. There's a lot of people who denigrate FAST as it doesn't influence care, and a lot of people, well, the disaster setting it does. Okay? Future crises, I don't need to dwell on the Wuhan coronavirus, the SARS-2 coronavirus, as it's now officially called. And notice that it sort of sits in the middle of epidemics between deadliness and spread. Sort of right in the middle, which means that, I sure hope we don't get any more boxes out here, but they could. A few last minute points about traumatic brain injury, and then I promise I'll wrap up. The lack of appropriate training and experience makes operative therapy more dangerous than medical management. So unless you're a neurosurgeon or being coached by them, I would strongly recommend medical management for traumatic brain injury. And you can actually do a lot of good that way. Because what's the two things that kill brain injured patients? Hypoxia and hypotension, right? I know what to do with those, or at least I know interventions I can do. And I'm not a neurosurgeon, and I've never done some heroic, burr hole drilling, and frankly, I hope I never have to. There are infectious issues because it's a very dirty environment. Hand washing and basic antisepsis. A high percentage of people will be infected, and hey, guess what? They come infected with nasty pathogens, not the usual benign, pan-sensitive staph and strep that we get here in the United States. This is from another one of these mass casualty disasters. This was the tsunami that hit Southeast Asia in 2004. Some of the injuries, and what was the point of this is that they all had a lot of very nasty pathogens, acinetobacters and pseudomonads and all those dirt bugs that actually, if you think about, kind of make a lot of sense with people who get exposed to dirty water and trauma. A few more basic principles, and really this is the point I would leave you with, that even in the austere situation, basic principles count. Basic vent management with head of bed elevation, oral care, low tidal volume ventilation, turn the tidal volume down. DVT prophylaxis, beta blockade, and tertiary surveys in which you're just reassessing patients. You have your clinical skills with you. Manage your minds, manage your team. Keep in the back of your mind that this is going to be a traumatic experience for everybody, and that there's going to be a notable rate of PTSD. And get creative a little bit with the nutrition. People got to eat. Last few words about triage, and I promise I'll wrap it up. Occasionally, there are people who you have to triage out, And these are the guidelines. And generally because these are people who have very low probability of survival. Basically cardiac arrest, very high trauma injury severity scores, and severe anoxic brain injuries. But as we said, these guidelines are a little bit fluid, and I get your attention back to Dr. DuBose's experience. They had 6 patients. They had the capacity. They did something heroic, and it did work. So these are guidelines, but they're not absolutes. And of course, when the triage, and I put this slide in just so that it's a dynamic process. You always reassess and you always re-triage people. So these are my conclusions. Here's the takeaway, and I'll just leave you with this slide. The preparation, make sure that your unit is prepared for the surge. If you're deploying, make sure that the equipment is there. Remain calm, don't panic. You know, the usual cliche about the Kipling poem, if you can keep your head while those about you are losing theirs, et cetera, et cetera, et cetera. Clinical impression means a lot here, and basic principles of critical care. The basics never change. Basics are always the same. They're there for a reason. Pool your personnel and keep in mind that you always think transport, so coordinate with your air evac, your people that will get them out of there, and make sure that patients are prepared to go. And I think I will finish here. I do want to thank my colleagues at the East Military Committee who were very helpful in this, as well as my Army buddies from my past life, my ex-Army buddies in my current life, and lastly, everybody who came here and for your attention.